My name is Tom Holt, and I'm the chairman of the board of NIASA. And on behalf of NIASA and our other co-sponsors here this morning, CCLC, ASHA, AARP, and our host, and its president, Bob Kerrey, we welcome you all to what we think is going to be a very exciting conversation this morning. With multiple parties involved in any venture, it can be easy to focus on the differences rather than those things that unite us. So I commend all of our participants for being with us this morning, because clearly we share a common vision and interest in bringing change to the way that we finance long-term care. We need a system that's not dependent upon the next state budget to determine what its goals is. I think we all understand that that type of planning will lead to failure in the long term. We find ourselves today in a situation where it's obvious that overdependence on a state budget is placing the provider community at risk, and the future for many at this time is uncertain. But what's exciting to me about this forum this morning is that we come to it with the spirit and understanding that whether you're a provider, a payer, a regulator, a legislator, or a consumer, we all have the same goal. We understand that the current system for financing long-term care is broken and change is imperative. As a provider, I know what's happening in my own community. The elderly population is growing. There's an increased demand that's only going to get greater for less institutionalized models of care delivery, and we've got a taxpaying community that's demanding less and less spending on the Medicaid budget. These three pressures are going to dramatically impact my community as we go forward. And while we will be primarily discussing financing strategies this morning, it's essential to keep in mind that our end product must focus on enhancing the quality of life of our mutual constituency, our society's most vulnerable citizens of all ages. So thank you all for your participation this morning. While many challenges are obviously ahead of us, I really relish the opportunity to be a part of a meaningful change experience. I'd like to introduce Bob Kerrey, president of the New School, for some comments.
Thank you very much, Tom, and thanks to all of you for coming here this morning. I actually had some prepared remarks that we worked on a couple weeks ago, but things are changing so fast in our country right now that the remarks I had don't seem to be terribly appropriate. I would say at the beginning that I had the experience in 1969 of spending about 8 months in a hospital in Philadelphia, and it taught me a lot, probably the most important experience I've ever had in my life. In terms of learning things about life itself. Most important of which is that going into that hospital, I thought that the measure of a man was his capability and willingness to take care of himself. And I went out of the hospital recognizing that the measure of a man is the willingness to let somebody else provide care to them. And I got a lot of care from both people who were paid and volunteers who helped me put my life back together, and had a fair amount actually on and off over the next 8 or 9 years. So I come to this topic with a recognition that all of us at one point in our life are either going to be receiving care or giving care, and it's as good a measure of our humanity, our willingness to both receive it, to show it let other people love us, and to give it in return. Not when it's convenient, but when it's inconvenient. So I thank all of you for, in particular, doing the latter. This is going to be a very challenging time going forward for this country. Those of us who are enthusiastic about Barack Obama expect him to win on Tuesday. Joe Biden, I guess a Sunday or so ago, made a very famous remark in which he said that Obama's medal is going to be tested by Islamic terrorists. I actually think that's less likely with Obama than it is with McCain. I think it's less likely as a consequence of who he is and the changed nature of the attitude of the world towards the United States, which will occur immediately after he is determined to have 270 electoral votes. Where his medal is going to be tested is here at home. And all of our medals are going to be tested. I don't think there's going to be a state in this country that isn't sitting there right now, a governor that isn't sitting there right now saying, I don't know how to cover my costs. I have insufficient amount of revenue, and they can't print money like Washington can. And you can sort of expect to see, I think, significant pressure on budgets in all 50 states, and probably every major metropolitan area. And it's going to have real impact on our capacity to provide educational services and care services. No matter where we are in the continuum, it's going to be exceptionally difficult for us to get that done. My own strongly held view is that normally what happens during the transition from an old to a new president is a considerable amount of celebration. And we're going to have about 24 hours to celebrate, and then we're going to have to answer the question, what are we going to do about this? And specifically to this group of people, I think that we need to focus on what the lame duck Congress is going to do. It is highly likely there's going to be another stimulus package. And I would make certain that long-term care is in that stimulus package in one way, shape, or form, and that it needs to be different than the aid that's been currently going out in the package where $125 billion gets invested in banks and then they don't loan it out. That's not a good plan, in my view. And I don't even think $600 for every American to spend is a good plan. We need to make certain whatever goes out in public spending creates jobs and lifts incomes. That ought to be the measure. Because it's likely in the week after the new president comes in that jobless, the increase in number of people who have been terminated from employment is probably going to be north of 200,000. If you want me to predict, I'll predict that you're going to have significant bankruptcies as a result of consumers out of the marketplace over the Christmas holidays, and it's likely you're going to come in January when Obama takes his hand off the Bible and becomes president of the United States. You could have unemployment pushing 10%. It's not like anything we've had before, and it couldn't happen at a worse time. At the moment the baby boomers are about to retire, a generation that hasn't saved enough, that was counting on the value of their homes and their 401k accounts that have disappeared. And it's going to put all of us in a funk, in my view, unless we do a number of things. First of all, we got to rebuild this country. The president's going to have a very difficult time getting out of Iraq. We got to support the strategy to get that done. We got to pull back those overseas commitments, not, in my view, in an isolationist way, but in a way that says we've got to rebuild this country. For my money, the government, the federal government of the United States right now is not over leveraged. There's borrowing capacity that's still left. And I don't know if you all remember Desert Storm, the war that drove the Iraqis out of Kuwait. Colin Powell did something rather unusual at that time. He asked his military leadership, how many troops is it going to take? And they said 250,000, sir, and he said, fine, we're going to do 500. That's what I would do with a stimulus package. Ask all the leading economists and tell me how much do we need to put out there to create jobs. And if they say, they're likely to say $500 billion, I said, fine, we're going to borrow $1 trillion. We could borrow $1 trillion today and put it out there in healthcare spending, put it out there in a policy to actually devalue petroleum and create a different energy policy. We could do the same thing in communication and transportation. There's all sorts of things that would create jobs. It would put people to work, not in a make-work fashion. There's huge capital needs, as you all know, in the long-term care area. If the money is available, there's going to be people out there actually working. I'm not talking about the government creating jobs that aren't needed, but putting contracts out there and putting money in long-term care in particular, putting money in federal labor programs that could stimulate and actually create some career paths in the workforce, which is probably one of the biggest challenges that the Long-Term Care Commission identified, at least a challenge that can be solved. If we can get a stimulus package that's sized like that, I think there's a very real chance that we can, instead of having this be the worst recession, because these things have a way of getting out of control. If the consumers pull back and you have bankruptcies going up, revenue's going to pull back, and if everybody starts to pull back on all their expenditures, it just gets worse and worse and worse. And if you don't think we could be back with unemployment rates in the 20s, in my view, you're wrong. It could happen. And you've got to stop it with something that's big, not something that's small. So we're going to have to give President-elect Obama, in my view, permission, and you got to put pressure on that lame duck Congress not to come in and out of town without doing what's right, which is to put something out there massively to stimulate the economy. With that done, in my view, you'll see unemployment flatten out. You see the economy start to grow again, and then we can start talking about how we're going to finance long-term care. Don't wait, in short, for the new Congress to come back in January. This is one of those situations where if we wait, if we don't pay attention to that stimulus package, we could come back in January and find ourselves in a lot worse trouble than before. So anyway, I thank all of you, most importantly, for the care that you provide, for the commitment that you've made to take care of people in need. It is the measure of our humanity. Nothing else measures quite like that. Nothing else really determines how good a people we are as individuals and collectively than answering the question, how willing are we to take care of somebody else who needs us? Thank you.
Thank you, Bob. Next, we'll be hearing from Joe Baker, Deputy Secretary of Health and Human Services from the State of New York, and then following Joe will be Mike Burgess, the Director of the Office for the Aging of the State of New York. We hope to have the opportunity to do a little bit of Q&A after these two presentations, so I'd ask you to give some thought to that as you hear these gentlemen speak. Joe?
A little narrow up here, so I made it. Thank you, President Kerrey, for those remarks, and certainly your thinking on these issues I think will be very important in this new period that we're entering, and I can't really add anything to say I agree. And the governor, as you know, was, just to speak to this topic a little bit, was in Washington on Wednesday testifying before Congress. And of course, giving a stark contrast to Governor Sanford of South Carolina in requesting that Congress think through very carefully a stimulus package for all the states, making, I think, a particularly compelling case for New York, given the epicenter of the financial crisis here and the historical reality that New York is, has sent more dollars to Washington than it's gotten back through the years. Something that, of course, our New York delegation knows. And I might add something that all you know, and I've been really heartened this fall by us all, many of you in this room, through your associations or individually, coming together and working with one voice in Washington with us to push this federal stimulus agenda. I mean, it really has been, I think, a great symbol of coming together in a time of crisis and understanding that we need to work together in order to help this state move ahead and protect New Yorkers, the most vulnerable New Yorkers, many of whom you serve on a day-to-day basis. And the governor has in mind as he is looking at some of the difficult decisions that he needs to make and then we all need to make with the legislature and with you as we move ahead and do our budget this year. First in November for our special session to deal with a $1.5 billion deficit in this fiscal year, and then in next year projecting that $12.5 billion deficit. Definitely interesting times ahead, and it will just be, 2008 in Albany, continuing. And certainly we do appreciate, and I do appreciate personally, the support and the creative thinking of many of you in this room that we've had the benefit of, and I know that we'll continue to have as we move ahead in this, next challenge. Let's turn to long-term care, and I want to give you a snapshot. Many of you know some of these statistics, of course, or all of them, much better than I do, since this is your, breath of life, as it were, in your daily work. But also give you an indication of kind of some of the things that we're thinking. We're thinking through the budget for next year. This is a year that we do want to focus on long-term care and make some reform recommendations, many of which you have already informed through a variety of efforts. We all know that New York spends a lot of money on long-term care. We spend about $995 per person annually on long-term care Medicaid expenditures, compared to about $376 nationally. Between 2000 and 2015, and Mike is going to talk a lot about these demographics and statistics, New York's population, 65 plus, is expected to increase about 18%, from 2.5 million to 2.9. And by 2030, the increase is going to be very dramatic, 51%, reaching about 3.7 million. Now, probably Mike has all different numbers than I do, so, but it's going to be a big increase. We're also looking at increased spending. And, you know, we always talk about the sustainability of this spending. And, of course, in any challenge, we're always talking about these kinds of issues. Will we be able to meet the challenge? Even with these kinds of numbers, I'm sure we will meet this challenge. We have to meet this challenge. But it is an amazing challenge ahead of us. Our spending levels in long-term care and in health spending overall, depending upon which statistics you look at, anywhere from 7 to 15% over the course of the next, 10 to 15 years. And families and caregivers really stretch to the max. Families and caregivers who really are the unsung heroes of the long-term care arena stretch to the max, currently estimated to add about $20 billion to the formal cost of long-term care expenditures, almost half of what we're looking at with regard to long-term care expenditures. And as we look ahead, and Mike is going to talk about some of these numbers, but I don't think anybody disagrees that the number of workers and the number of caregivers, is outpaced by the number of folks needing care as we look at the demographics looking out. And of course, with the changing, nature of America's families, that's even becoming more, let alone the baby boomers, but the fact that people don't live next door to each other as much as they do, et cetera, and this dislocation in the economic system, that we're going to have further strain on family caregivers. And one of the things that Mike is working on with others in state government has brought together a group called the Caregiving Council that is trying to look at various things that we can do to support caregivers and encourage caregiving. So something that is going to be a continuing challenge and something that we're going to have to make continuing investments in. The state has a very, I would say, and is in many ways a national model for the array of care that is available to folks. We've got, of course, the nursing home system. We've got an array of other levels of care in our home care system, our long-term home health care waiver. We've got our nursing home transition and diversion waiver. We've got our TBI waiver. We've got a list of those waivers with all those lovely alphabet letters down our arm. Yet this formal system of state programs is complex, and we know, and very sometimes unnavigable for folks, but it can be fragmented, leaving people with a lot of barriers to access, unmet needs, reliant on a fragile network of informal care to fill in some of the gaps, and impoverished in many instances, either by out-of-pocket expenses or the transfer of income and resources to qualify or access public programs. And while New York expenditures per Medicaid long-term care recipient, as I've discussed, are the highest in the U.S. or among the highest, the relationship to quality is really unclear. In many ways our quality is better and improving, and in other ways it's not. So we can't say, oh, we spend the most money and we have the absolute highest quality. And that is something that I know we're all concerned about and continually thinking through and working on. So what are we doing? We're at the moment in our budget making process preparing a bunch of proposals that I think represent the start of a comprehensive initiative to take a look at the care that we're providing and make sure that we're providing the right incentives for the right kind of care. And that includes institutional settings as well as non-institutional settings, rewarding quality and trying to shift folks to the right care in the right setting at the right price. And I guess that has been one of our mantras and something that many of you who also operate and work in the acute care area may very well have heard me talk about in the past, and certainly our Medicaid director, Deborah Bacharach, who's unfortunately not able to be here today, but others in the administration have said, and that is that idea of value, of right care, right setting, right price is very important, and one that I know many of you are working on as well in the spectrum of long-term care. Trying to create those integrated systems or work together as different sets of providers to make sure people are moving through a continuum of care at the right pace, at the right time, and getting the quality care they need. And I think New York's Medicaid programs, in many instances, as I said earlier, are the envy of the state. You know, I had a meeting yesterday with folks in the OMRDD area, and we've talked about how really New York is the envy of many other states there. And even as we reform that system, we want to make sure that we're taking all that's the best in that system and improving it. And there are things yet to improve in that system. So that's what we're looking to do in long-term care as well. We're going to, as I said, invest in, and we hope to invest in systems that reward quality, provide uniformity across programs and settings, increase appropriate capacity and utilization, and increase efficiencies in order to really be able to sustain what we want expanding services to an expanding population. And I think that there are a couple principles that reform our decision-making and our thinking in this regard. One is we do, and we are, and this tends to be a word that's misused in a lot of situations, and I don't think we're doing that, but really want increased consumer choice and control for older individuals, persons with disabilities who we cannot forget in this discussion, and folks with chronic illness. So really making sure they have real choices that they can make and control over the care that they need. Ensure access to a wide array of home and community-based long-term care and institutional care when necessary. And that's that array of services, that continuum of services. We want to make sure that there's no, misaligned incentives for anybody to go to one place, whether it be institutional or non-institutional, that may not be appropriate then because of financing or because of other misaligned incentives. We want to enhance quality measurement. One of the things that we've tried to do, and I know many of you are working on very hard, is getting that data. And it's not something, frankly, that many of us, some of us are quite ashamed of the fact that we're, the travel industry or the hospitality industry or other industries are much further along in using IT and other tools. And those are something we definitely need to bring to bear and some investments that we need to make there. So getting that data and making policy on that data will continue to be a challenge. And in many instances in the acute care and other areas, we have taken small steps in the first few years as we also require providers or others to accumulate data so that we can determine whether those steps are the right steps to take or there needs to be a change in course as we do analyze that data. So the data that we've been receiving in the Medicaid program in acute care and primary care and other levels of care has been tremendously useful, and in the long-term care area as well, and I think that needs to continue. We need to, surprise, surprise, reduce costs, and we need to, and in doing so, we need to promote payment mechanisms that reward better performance. So that's definitely there, and sometimes we're just going to, frankly, have to reduce costs, and by that I mean reduce state outlays, and that's going to be, in many instances, painful. And we're going to need your help in deciding, where that pain can be best felt, as it were, or best tolerated. We want to encourage personal planning. So once again, I know one of the focus of today is to really talk about personal planning, personal responsibility, taking a look at how people can better deploy their own funds and resources in the long-term care area. And I think one of our goals is that we need to be leaders. We need, as a state, to be a leader in purchasing value because that is what our taxpayers expect. But in doing that, we will also create a marketplace in which it's easier for individual consumers to purchase value because their market power as individuals will not be as strong as ours. So we need to make sure that we're working in tandem and that we're leading the way for them. Improve coordination of services, not only within the long-term care field, but also between acute care and long-term care. And as I said earlier, work on the health information technology. And support and enhance family caregiving resources. That's something that we're going to continue to want to do and work with you about, along with working on developing our state's workforce in this area, because that will be critical, and also something that we think might be able to work in tandem or hand in hand. Discussions like the one that we will have today really assist us in developing sound policies that engage, both state and private and national policymakers in creating a system that I hope will meet these principles or begin to meet these principles. Today, as we've heard and we know, we're facing a real challenge in the state and nationally. And the governor has made it very clear that we don't want to use in state government the fiscal crisis and the financial situation that we're dealing with, economic situation we're dealing with, as an excuse for stasis or as an excuse to sit still or not move ahead with reform efforts. I think we certainly need to calibrate those efforts. I think we certainly need to take a look at investments, but there's a real impetus and a real charge by the governor to keep moving ahead with reform, to keep moving ahead with change, some of which just has to occur in the context of the budget, but much of which may occur without financial expenditure or with very little investment, but point the way to reform and point the way to where we need to go as resources again come into the fray. So I think we're going to have a very tough season in Albany. Not to say that it's been a bed of roses heretofore, but I think it's going to be a tougher season, as it were. And I've been heartened over the last few weeks at the level of support, the level of creativity, really the level of commitment that many of you in this room have shown, and many of your colleagues have shown across the healthcare spectrum in coming to the fore with some creative ideas and some thoughtful proposals. And regardless of whether you see them or not in the budget or you're happy or not within the budget, I think I can safely say that we are as accessible as we possibly can be, and we're looking forward to engaging with you with your thoughts and with your concerns. So with that, I'll stop and thank you very much.
Thank you, Joe. If we can coordinate our moves up here, next we'll hear from Michael Burgess, Director of the Office for the Aging.
Yeah, you're going to just help me. I want to thank Carl Young for getting a lot of us from Albany up at 4 o'clock this morning on the 5 o'clock train, and seeing the sunrise in New York City. And Senator Kerrey and Joe, yeah, I would say that 2 governors and 1 depression in 1 year is a lot, you know. And next year, hopefully, it's not going to get worse. But anyway, here we go with my job today is to talk about the demographics. The age boom is coming, the silver boom. What we have here is the 4-year plan that we have to submit to the federal government, and this is the link to it and to some of the charts that we'll be showing today. And I think it's so important that we're having this discussion because the financing of long-term care and some of the things you're going to talk about today really are so important in light of what we're hearing about the changes in the stock market and the loss of income by a lot of older people. This chart shows you really using 3 years, the blue one 1950, then 2000 and 2030, just the percentage of people in the population and how the 60 plus and the 40 to 59 plus or 40 to 59 age groups are growing so much more as a percentage of the population. I think we know a lot of this. A lot of you have seen these before. These are the national numbers. You know, right now, I believe we have the same number of 5-year-olds as 50-year-olds, and in 30 years, it'll be the same number of 80-year-olds and over as 5-year-olds and younger. So that is a really daunting number when you think about that. And in our state, we're projecting, you know, by 2030, I believe that is on the far end, that we're going to have 25% of the people be age 65 and over at that point. We're creeping up through the teens at this point, but it's going to accelerate as a lot of us move into that age group. And this is really an important kind of focus. It's not only the change in the age group, but what makes up that age group. The older minority numbers are the top one there, and they are growing at such a high rate. But also, when you look at this, the 85 and older are the second line, and that's almost 40% or more over this time period, just from 2000 to 2015. Disabled as well. So, you know, these are the kinds of challenges that we're going to face in the long-term care system directly. This kind of gives you an idea of counties that by 2015, what do we have, 54 of them are going to be at least into the 20% of their population are going to be age 60 or older. So it's really 52, 53, 54, right, that's what that is. So it's really changing a lot, and you know, the loss of young people upstate makes these numbers look like this to some extent. We have so many, you know, we're losing population, and we end up having, and especially in the rural areas upstate, a large percentage of the total population is older. Now this is the chart that I always talk about. This is really amazing. This is the out-migration and in-migration of population in the state of New York. And you see the left-hand side is the younger ages, and that may be due to immigration. You have young people coming in with their parents. Then they leave in this first dip in their 20s after college. They come back again maybe to work here in New York in their 30s. And then there's a slow decline all the way down into the retirement years. It goes under, a loss of population by age. And then look at what happens. The number goes, starting around age 80, we go up. And what does that mean? I guess we think it means that people are coming home with to their families, and caregiving becomes that much more important. And maybe it also means they like New York services better, which is a mixed blessing, but it may be the case. We hope it's the case in some regard. But here's what we face, this ratio of working age adults going down, even from last year when we did this to 2030, to 3 to 1. So we all know that. We've seen that kind of figure before. And it's compounded by the fact of the changes of the people who are working, and particularly in nonprofits and the public sector, losing a lot of people. And I know in our office and many state agencies, we're talking about 30% of the people who would be eligible to retire today. And so a big focus that we have has been on, you know, how do we not just view that as a deficit, but also how could we use older workers to help us in the years ahead. And I think more older people are going to have to be working anyway. So we like to say that, you know, older people are a human and social capital, social resource. And it's important for us to be using them not only here, but as we move along here, I'm going to show you about civic engagement and volunteerism as well. This is just another chart on the dependency ratio of the number of persons per age 60, and that, of course, declines. That's pretty much the same as the other one, 5 down to 3. Now, informal caregivers. We, as was mentioned before, I think Joe said, the Family Caregiver Council, which many of you are aware of, and is not just related to aging caregiving for the aging, but it's also all caregiving situations, and it's an interagency council, and we're chairing that. But we like to say that family members and friends start off with informal, or however you want to define it, care at 80% of the care is being provided there. And that's going to be especially important for us to maintain, and that's what the council is about. How do you support people who themselves may be 55 or 60 years old, who may have their own problems physically, and how are they going to be able to continue to care for older persons, or in some cases, it's funny, my uncle was telling me, who's 94 years old, I saw him last week, and he was talking about living as long as he has, and he said to me, and I never thought of this, and he never thought of it till he said, you know, I quit smoking when my 4-year-old granddaughter said to me, why are you doing that? You know, you're gonna kill yourself. And he decided that, you know, maybe he ought to listen to her words. But that's the kind of thing that caregiving, we always like to say, works in both ways, because it's not just younger people taking care of older, but we have so many, we have 140,000 older persons taking care of 400,000 grandchildren in the state of New York. Now there's a little bit here on the workforce, and these are some of the projections of jobs that will be needed and where we were in 2006 and what's projected in the red to 2014. And you look there and you see home health aides, registered nurses are key to this. Also social workers. One of the things not on that chart, but well, further on here we'll talk about human services workers, people who are working in the non-medical areas like the Offices for the Aging and other human services agencies. There's going to be a greater need also in the areas that we work in. But you see here about nurses' aides and the number that are projected to be needed and the increase there. The human services workers, they're actually, the need is projected to grow faster than all the other occupations. And I think that we're seeing a lot of that in our agencies, and I know there's certainly a move with geriatric social work to get more people involved in that dimension as well. Older workers, the bottom number there, I think we'll see go up, 15.5%. And I think many older workers want to continue to work part-time or whatever. We have to be very flexible about how we do this, that people want to have the freedom to work on a different type of schedule. But I, again, think we need to find ways to provide incentives for older people to work, and I think losing a lot of money on 401ks will certainly help in that direction. We are also, with the Department of Labor, have the Mature Worker Task Force, which is assigned to look at ways to retain, retrain older workers and how they can participate in the workforce. We haven't started with that. We're starting up.
The task force has not met yet later this fall.
Yeah, I know. I haven't been to any meetings of it, so it hasn't started yet. But it will be coming up shortly. And I want to also mention civic engagement and volunteerism. This is, sometimes you might think of this and say, well, that's kind of, as some say, fluff. I don't think it's fluff. I think that what Reserve is doing here in New York City, of having volunteers, stipend volunteers, following people home from the hospital on discharge planning, I think what the hospice movement has done. My father-in-law, I always cite, he's a 77-year-old man who retired from IBM and is Hospice Volunteer of the Year in Albany County, and because his wife died of cancer, he wanted to get into that. I think those are the types of things that are so helpful to the system, and we're going to need them. We're going to need people who are willing to fill in navigating. We like to use the word of a navigator, to navigate through the healthcare system. It's very confusing both in the financial insurance end, but also in the caregiving end, and arranging for people to, meet their medical appointments, even getting transportation to doctors and so forth. So we are one of 6 states that's been picked by the National Governors Association for a Civic Engagement and Older Worker Policy Academy. And we're going to come up at the end of this year. We've already met with the other states in Annapolis, Maryland. We're going to come up with a blueprint for how the state goes forward to maximize the use of volunteers, but also of older workers in the state. And we have civil service and the Department of Labor, AmeriCorps, and I'm sure a few other agencies I'm forgetting that are around that group. I just want to finish up by talking about the importance of prevention and wellness. You can't overemphasize that if we're going to deal with the problem of the financing, one of the ways is to do more with prevention programs, and a lot is being done. But I like to take this statistic: 350,000 Americans fall, 40% and break a hip, 40% end up in a nursing home, 20% never able to walk again. You can read this: poor balance, taking 4 medications, and muscle weakness are the 3 factors for falling. If you have all 3, if you have none of them, you have a 12% chance. If you have 3 of them, you have a 100% chance. We have to have fall prevention programs. You see here the rate and the number of people. We had 794 people, I think we had, who died of falls in New York State last year. It's an enormous cost to our health care system. And there are so many good things being done. We were at a NORC down in New York City here, Penn South recently, and they have a falls prevention program. And they were talking about what's the room that is the most dangerous. And people, well, we said it was the bathroom. No, it's the bedroom. because you're lying down, you get up, your equilibrium is off, you might be reaching for your clothes or your glasses or whatever, and you fall. We need to teach people about these kinds of things, and we can make some progress. We, in our office, are doing health benefits checkup program with Medicare, the preventive benefits that are available through Medicare. And you can see here the ones that are shaded are the ones we're doing a little bit better than the national average, but we're doing a little bit worse on some of the other ones. And what we've done in the office is to actually go ahead and map some of the states into quartiles of the ones in yellow or the ones doing the best in terms of pneumonia shots on this chart. We've done them with all of the diseases. And that gives us kind of an idea of where we might be able to do more outreach and efforts in this regard. I find this one, I wanted this one put in because being from the North Country, I said, why is it in yellow, those counties up there? And when I talked with some of the directors of the Office for the Aging, they said, well, we had a mobile mammography van that went out onto all the small towns, and we were able to, you know, screen a lot of people. So these are the types of specific things we need to focus on. So summing up, what we are doing, what the governor is doing with us in terms of volunteerism, family caregivers, I want to emphasize the Office for the Aging. We do all the non-medical stuff. We like to say, you know, we're pre-Medicaid. We want people to understand that home and community-based services, home-delivered meals, all of these programs, the caregiver stuff, transportation is one we always hear about, that if we can concentrate more and more on this and working with you, even though, you know, the association is a medical provider or a housing provider, we're working together on a conference coming up in a couple weeks on community empowerment for successful aging, where we're trying to bring people from all over the state. This is going to be in Saratoga the week after next. We're bringing people who are involved in housing and in self-help neighborhood programs and in caregivers and NORC programs and community planners and livable communities. We're trying to bring all these people together to focus on how can we improve the quality of life for individuals but also for communities by employing some of the things that we've seen here today. So I'll stop there because I know we're moving on with time, but I just wanted to give you that focus on what our office is doing.
Thanks, Mike. If I could ask the panel to come back up. I've been told that we do have about 5 minutes, so we have an opportunity for a little bit of Q&A. We do need you, though, to move to one of the microphones because we are taping the conversation this morning. So once we get settled, Bill, we'll let you go. Bill Smith over on my right.
Good morning. Thank you for your comments this morning. Our field is very, very labor intense. And when we look at the state shrinking its revenue for us based on the loss of revenue to the state and shrinking our reimbursements, et cetera, I hope that you recognize that 70 to 75% of our cost in many of our facilities is directly related to staff. So that when you shrink my revenue as per diems, I have no other recourse but to, in fact, lay off staff. My question is, the governor recently convened 3 major unions and had very serious, candid discussions with them, but there was no mention of any type of renegotiation or give-backs. We are at a breaking point at this point where we have contracted agreements with 3% increases over the next 2-3 years, and we're faced with shrinking revenue. How do we deal with that dilemma?
Well, I think, as I said earlier, we're going to have to come up with some creative solutions. I think that the governor, has met with various unions. There's some meetings yet to be had. Certainly, those meetings focused primarily on the public unions, with regard to state workers and the state workforce in various settings, but has met with, healthcare unions, 1199 and others. Certainly, there's 2 components to your question and comment. I mean, one is we are acutely aware of the things that we do and how they reverberate through the system. So, and sometimes, to be frank, some of the things we do, we hope that, the industry can find a way, and many times they do. In other instances, we are persuaded by your advocacy and education around the fact that some of the things that we propose aren't so smart or will, cut too deep, as it were. So we'll certainly need to hear that again, and and test each other in that way. You know, with regard to private, you know, management labor negotiations, you know, we have a limited, you know, role to play there, of course. That said, I think this is a governor that wants to be, as I said, creative, that wants to certainly use the bully pulpit in whatever way he can, and without, you know, committing him to doing that, we should certainly talk through as we move through this budget cycle about how, you know, what are the things that we can do to help you as providers lower your costs. And we've been talking to various of the associations about that. When I met with Carl, you know, he mentioned liability insurance, and certainly we've spoken with the hospital associations about medical malpractice, where, you know, we tried very hard back in August to come up with a solution there, and we had a round of meetings on Wednesday and Thursday about that very issue, you know, mentioned that we want to make sure to hear from the nursing homes as well. You know, Haney's and Greater New York were there at the table with us as we, as along with other, you know, med-mal interested parties. So I think those are the kinds of things that we're looking at, and certainly labor costs is something else we can look at. And we certainly want to put our hand on, first, on the things that we know we have the authority to do, and it's very clear. And then second, if there are other things that we also either need to be aware of, or maybe we need to, you know, exert some authority elsewhere, we need to think that through. But, you know, it's certainly the time to be creative in that regard.
Yeah, look, having been a governor as well, previously I've got some capacity to understand this issue, although in Nebraska we didn't have these kinds of labor contracts that you know, in the middle of cutbacks can put you in a terrible situation. I've talked to Matt Goldstein about it, and I know and understand what happens to CUNY. They get a cutback in their funds in the middle of a contract. It means they're almost forced to riff, almost forced to riff. And I think you have to frame it that way. You know, and it's not just going to be in labor contracts. It's going to be in pension agreements. I mean, I've been here long enough to get angry myself at the disability agreements that the LIR employees worked out. I mean, it's just there's some, particularly if there's a federal package that's going to be a part of this. You got to make change happen, because otherwise you can't get South Carolina to go along with it. Because that's basically what was set up earlier. Was the governor of South Carolina and the governor of New York have completely different approaches to solving this problem. And at the end of the day, I think the governor of South Carolina gets outvoted, because South Carolina is going to have as many problems as New York has with this economy. Secondly, I would say that in our report, we did in the 4 areas, in technology and quality and finance. The 4th one was workforce, and there's a number of very good recommendations in there to take Department of Labor programs and use them not just to solve this particular problem, but to try to create a real career path inside of the workforce. You know, from the CNA on up, and by on up I mean making sure that Medicare reimburses in a different way, so as to create more opportunities, and more likelihood when those physicians are going to school that they'll select professions that are likely to be you know, in this arena. Third thing I would say, and I didn't say it in the details of talking about a stimulus package, I do think thinking about a package that brings the governors in is enormously important. I was just telling Larry, the governors are enormous allies and important allies, and they can help answer the question, where's the real need? What creates jobs? Not only where's the real need, but how can I frame this so as to make other change happen, so we get more bang for the buck coming out of the transaction. Because it's got to be something, and just say it one more time, I'm very much worried that we'll wait too long, and very much worried that we'll be too timid in our approach. And again, I'll repeat, the United States right now, the federal government is not over-leveraged. It's one of the few entities right now in America that's not over-leveraged. Debt to asset or debt to income, we're still in the low 40s. $1 trillion worth of debt would cost $40 billion a year in interest. Only the feds can do this. So if they come in, let's say take 1/4 of it in health and with a package, and all of it ought to be packaged with the governors. The NGA, the National Government Association, comes to Washington every year in February. You could very easily engage the NGA. It's a very strong organization. The governors participate in it, unlike lots of other entities. So you could put something together, I think, in this area. And finally, I would say, just repeat, was struck by Michael's presentation. I mean, you've got this terrible demographic problem. You know, it wasn't caused by Ronald Reagan. It wasn't caused by secular humanists. It's coming to a theater near us, and it's going to swamp us if we don't get ahead of it. And when I see this data, what I see is you got to pay particular attention to those poor rural counties that are simply not going to make it unless you adjust in some fashion what the package provides.
I would add, I think that's absolutely right, and I think with, you know, I know the national associations that you're all associated with are going to be very critical, because we always have to be very careful when we're in Washington and we're talking about New York, and particularly Medicaid in New York, because we all think we have the best Medicaid program in the country, and I think we do. But not everybody thinks that, and especially some of the senators that you know, are very important when it comes to Medicaid debate. So it's important that your national associations are working with other states, because they're usually right behind us on our flank. But it'd be nice if they were a little bit out front sometimes too. And I think Governor Patterson has been very aggressive in Washington and wants to continue to be, but we're not going to succeed without other states also coming to the fore. And they have. I'm not being critical of them, but we need to keep that pressure up. And I think another thing on workforce, you know, last year, you know, once again, we had a limited amount of money to invest, but we looked at nursing, and it's the nurses. It's part of the light show that I present every time that I come to these events to distract people from the economic crisis and the fiscal situation. I'm just going to talk through that because I'm loud. But, you know, one of the things that we worked with the Nurses Association and the hospital associations and other interested stakeholders is where would we get the most bang out of our buck if we were to invest in nursing and to try to increase the number of nurses in the state. And, you know, because we originally thought, frankly, well, we need more scholarship money. You know, we need to, and they were like, no, 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 no. We need more nursing faculty, because we're turning them away from schools because we don't have, and then after that we probably need capital money for nursing schools, we need more labs, we need more, you know, practical space, etc. So we weren't able to do the capital stuff, but we were able to make the investment, and we thought, okay, yet again, where's that money going to go the furthest? And we thought SUNY and CUNY, and not to say there weren't other worthy recipients, but so that, I think, is the kind of thinking together that we can do to, you know, really deploy our dollars, you know, most effectively, and we're going to need to do that even more. But I always point to that as a kind of a successful negotiation, that it wasn't as much as we wanted to do, but we made sure that it was used in the right way, in the most effective way, and that's what we're going to need to
yeah, just one additional detail, Peter, trying to figure out Washington a little bit. I mean, the strongest caucus in the House and the Senate is not the urban caucus, you may have noticed. The strongest caucus in Washington, D.C. is the rural caucus. Republicans and Democrats unite in that particular area. So if you're looking for a way to put a package together, I really would drive this thing through rural representatives in New York.
Thank you. Doug told me when our time was going to be done, he would give me a sign. I thought it might be a little more subtle than what he chose.
Fire alarm?
A hand wave would have been sufficient, Doug. Again, Bob and Mike and Joe, we really appreciate your time being with us this morning and certainly serving as host for us today. We appreciate it. Give us just 1 minute while we transition to the next group up here, and we'll be right back. Thank you.
Thank you so much.
I want to thank our previous panel, and I want to especially thank our co-sponsors for helping us with this event. And I want to thank Bob Kerrey for being the co-chair of the National Commission on Quality Long-Term Care. We refer to it internally as the Kerrey-Gingrich Commission. Most of you would have bought tickets to watch Bob Kerrey and Newt Gingrich co-chair something. That in itself is a black tie fundraising event that someone should capitalize on. but the two of them, along with 20 other distinguished citizens in the country, including 2 governors, 2 senators, 2 members of Congress, and other thought leaders, took on the responsibility to say, what do we do about long-term care in America? Because we're paying less, we're expecting more, we don't like the quality we're getting. Everybody's experiencing these problems. We keep throwing more and more money at it to get less and less for people to be places they don't want to be. Is this a great country or what? And their report, which is out there, frames the major pillars of policy consideration, and they have to do with how do you define and measure quality, how do we pay for it, what is the technology that would take to make it easier to deliver, and most importantly, how do you attract and retain talented people to do this job, talented people from bedside to boardroom, because it's all about the caregiving. Now, Bob has put on the table here this morning I think a very powerful potential short-term solution around a service stimulus package. I like that idea, and I like one of the things we want to come out of a program like this today is, are there short-term and long-term things that we can get our arms around together? Policymakers, consumers, providers, labor, friends, and other groups. Longer term, we recognized at our association that we can't survive and deliver what people need bobbing for Medicaid nickels that are continuing to dry up on us. So do we throw up our hands and say, well, we'll wait for the government to solve this problem for us and keep coping with what we deliver, or do we take responsibility as a nonprofit provider association and begin to say what should be done, how do we know, where do we get the data for it, and who are our friends out there that we have a lot in common with? And we began to find lots of friends. So we put a thought leadership group together represented by several of our leading members in this room to say, how should long-term care be financed? And we found out that groups like AARP and others were beginning to think along the same direction. So we raised some money from among our members to say, how do we get beyond just producing a report that we distribute to people and create some public dialogue, and that's why we're here today. This is our 5th one of these forums, and we have several more planned in other states to get it on the agenda. And we're finding friends and thought leaders who say we need to look at this differently. So Bob's put out there today a short-term idea that I think has a lot of potential, and what we want to do now is begin to think, how do we think long-term, because the problem of caregiving and the financing of it gets more difficult every day. So we're honored today. We want to have 3 different perspectives about this. One from AARP, and we're honored to have Louise Ehrenstein, who's the state director at AARP, that's going to comment on AARP's perspective on this, and we really appreciate your coming in, and especially stepping in at the last minute. Y'all be really nice to her. And we'll report back in Washington that we're glad we had you instead of some of those Washington people, you know, those Washington people. And then I'm going to talk about ASA's perspective on this and the work we've done. Then Mark Melman, we retained the Melman Group and one of his other side of the aisle pollster groups to ask 1,000 registered voters, what do you think about these problems? And he's going to show you the results of that so we get to the level of what is the public appetite, if you will, for change. Louise, we are very appreciative of your stepping in, and come tell us AARP's vision of this. Lois. I'm sorry, Lois. My apologies.
I'll answer to anything today. So I'm filling in for Susan Reinhard. Some of you may not know her from our Washington office and our Public Policy Institute under John Rother. And forgive me if I'm reading her remarks, but I will read it quickly because we're New Yorkers and we talk fast. Okay, so, but there is a lot of information here, and I think especially about the kinds of legislation we're going to be supporting on the national level that I want to share with you. So the focus of AARP's advocacy will be as the healthcare reform as healthcare reform begins to be addressed at the federal level. We want to make sure that long-term care is inclusive in healthcare reform, not separate and apart, but really sort of a holistic healthcare reform package. Long-term care support services are a very big focus of AARP because they're usually paid for out of pocket by our members, by individuals, some by private long-term care insurance and Medicaid and the Older Americans Act programs, state and local programs, or provided by family caregivers. $350 billion in 2006 was the estimated economic value of family caregiving, and that is the backbone of long-term care in this country. However, family caregivers need support. They need information, education, training, and respite care to help them with their caregiving roles and enable their loved ones to remain at home, potentially delaying or preventing more costly institutional care. Medicaid, the largest payer of LTSS, which is the long-term care support services, is biased towards institutional settings rather than home and community-based settings where individuals prefer to receive services. For example, a recent AARP report found that nationally 75% of Medicaid long-term care spending for older persons and adults with physical disabilities are paid for through institutional services, with only 25% going to home and community-based care. Yet, among individuals age 50 and older, 89% say they want to remain in their homes for as long as possible. In addition, Medicaid is available to only those who have low incomes and limited assets or face catastrophic costs. Individuals with multiple chronic conditions often see many providers, take many medications, receive services in multiple settings. Care coordination is really important and communication across providers and settings with the individual and their caregiver is critical. And that, of course, can improve health care quality and outcomes and potentially save money. So AARP is supporting those issues, ensuring that quality of care and quality of life across all settings. And that is that institutional settings are necessary as well for frail people, but are as well as home and community-based care. Much progress and innovation on long-term care has occurred at the state level, and I will mention a few of those later. But there are important steps at the federal level that consumers and their families that we all need to take. We need to expand health, home and community-based care, improve quality across all settings, strengthen the long-term care workforce, and provide better long-term care financing tools. That is the basis of AARP's agenda. Any long-term care solutions should involve a shared responsibility of government, individuals, and the private sector. That's what we believe. Action is needed now so that consumers have more choices and do not impoverish themselves to get services that they need, so that strong infrastructure and systems are in place to provide assistance to the growing number of older adults and younger people with disabilities who need long-term care support services. So here's our legislative agenda on the federal level. HCBS, enact the Empowered at Home Act to provide greater access to Medicaid, HCBS, a caregiver tax credit, tax incentives, and improved consumer protections for private long-term care insurance. Chronic care coordination, enact legislation to improve chronic care coordination for those with multiple chronic conditions, such as the Independence at Home Act. Family caregiving, enact legislation to be introduced in 2009 to establish a Medicaid family caregiver assessment demonstration program to help determine the needs of and get supports to primary family caregivers. Nursing home quality, enact the Nursing Home Transparency and Improvement Act to increase accountability and transparency and improve nursing home quality. Workforce, enact the Caring for an Aging America Act to help ensure a workforce trained to meet the needs of an aging population. Elder abuse and quality, enact the Elder Justice Act and enact the Patient Safety and Abuse Prevention Act to expand successful pilot programs on long-term care employee background checks. Long-term care insurance, enact the Long-Term Care Affordability and Security Act to provide private long-term care insurance to be offered through employer-sponsored cafeteria plans and flexible spending arrangements. On the regulatory front, the new administration must revise or rescind 6 harmful Medicaid regulations that Congress put under a moratorium until April 1st, 2009. Of particular concern to AARP is the regulation on case management that would impede efforts to get people out of institution and into home and community-based services. Other regulatory priorities include revisions to Deficit Reduction Act rules for asset transfers to ensure that people who wish to help family members or charities and are not trying to cheat the system are not penalized. Home equity, so that people can get the long-term care that they need. So what is the cost of inaction? Failure to address long-term care issues at the federal level will mean a continued patchwork approach in which choices are limited and of inconsistent quality. People must impoverish themselves to obtain and not be able to find the services they need. Government frequently pays more for services that people don't want. There is a shortage of long-term care workers, and family caregivers are strained and overwhelmed. On the state level, we will be fighting the good fight. We expect huge Medicaid cutbacks, and so we are going to be looking at those and joining the fight in terms of trying to keep the most vulnerable older people, giving them the choices that they need, with a focus on home and community-based care as well. And that will be our major focus in the state. I also want to mention Work Search. We have a tool that we are going to be implementing in New York that will be put into communities like Harlem, Yonkers, other places around the state that will match employers to people who are searching for work, particularly low-income people. So our Work Search tool is a way that we can match people for the long-term care industry, and we're going to be looking to work with providers to list employment opportunities and recruit workers. So we are very interested in career path. We're also interested in establishing volunteer opportunities in the community to keep people living in their homes longer. So volunteers who provide home-delivered meals, telephone reassurance, friendly visiting, money management, and support services that we can bundle so that each community can keep people living in their homes longer. Thank you.
Thank you, Lois. And AARP has materials. They've been doing studies around the financing and their own polling. And I think if you look at the Divided We Fail campaign, in which AARP, SEIU, and the business community, one of the major planks there is long-term care reform. So you're beginning to get in stereo the fact that something can and should be done. Now, if you look on the front of your brochure, the first hurdle we've had to get around with politicians is, don't we need to reform long-term health care first? That's been a huge debate. and the Kerrey Gingrich Commission came up with is critically important that policymakers at all levels understand that you can't have health care reform without a complementary solution to the long-term care crisis and vice versa. What I'm going to lay out for you today around a national insurance model that's very consistent with the principles that Lois laid out and is based on Pepper Commission work a generation ago. If a plan like this had been in place today, Medicaid expenditures for long-term care would be 50% of what they are today. Now tell me what the discussion would be like in this room today if we had solved this problem when it was recommended that it be solved. So let me start there. Rosalind Carter said once, there are only 4 kinds of people in this world: those who've been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregiving. And it is a phenomenon experienced by most families. Long-term care is misunderstood. Most people think it is largely nursing home care. We believe that long-term care is a constellation of services and supports that provide attention that people need when they need it in a place they call home. So we have to begin to take a broader definition. The scope of the challenge, young and old in our country, you have a 75% likelihood of needing long-term care. In addition to the millions who need assistance that are older, close to 40% of those are under 65. So it is not just an elderly problem, it is a much broader problem than that. Where is care currently provided? 80% at home. You heard that. In Minnesota, where we did one of these forums at the Humphrey Institute, because of their policy over the years of incentivizing institutional providers to get into home and community-based services, 90% of their long-term care now is in people's homes. The caregiving commitment is 35-hour-a-week job, and it's mostly delivered by women. We're not saying that's the way it should be. It's just the way it is. We know that that caregiving commitment is, for 52% of them, is a 3-year challenge. And for a third of our population, it's a 5-year challenge or more. We hear about Medicaid. Private insurance is 4%. We're not against private insurance. It's just that it has a limited market. And we believe that the long-term care private insurance market could be redefined around more supplemental policies. Think about how successful Medicare Part B supplements have been, and that would broaden their market considerably. So it's not an either-or, and we'll have people that will say, are you against something because you're for this? No, that's part of a public-private solution to the problem. Also, in private long-term care insurance, many people are screened out, and the very people that who have certain chronic illnesses that run in the family could find themselves not able to get it. The public funding is 28%. You'll be surprised maybe to know that families and unpaid caregivers are funding 68% of the expense of long-term care today. Now, as we think about that 68%, you say to yourself, well, how could that be? If 80% of it goes on in families' homes, we know that the Alliance family caregivers are spending on average $5,531 a year out of pocket. How many of you have been, are, or anticipate being family caregivers? All right, how many of you who have done that or doing that have written a check to help with that? Well, I rest my case. It's us. As we move along, one of the silent potential partners in this kind of reform is business. The cost implications for business are already $2,000 per employee, and that's for lost days at work, stress-related illnesses. So we know that we're already paying a tremendous amount of money out of pocket already for long-term care. The cost implications for government, $100 billion and growing like a rocket. I mean, it's just heading upward, and it's affecting all of us. And the interesting thing is we're already spending lots of money for a system we don't like. And what we're saying to policymakers is, let us show you the numbers of how there is a solution to this problem that actually is viable. Rose's story, grandmother of one of our staff members, common story, teacher, lived in New York, saved, did everything she was supposed to, got to the point that she had to move out of a modest income apartment, didn't need a nursing home, but had to because that was the only option available. Her husband, her son drives 100 miles round trip, starts spending out of pocket $10,000, then $15,000, and Rose goes to a nursing home and dies with $400 in the bank, and son Steve has depleted part of his savings. It's a common story. The numbers you've seen, and they continue to grow around moderate disabilities and severe disabilities. So we believe that this situation begs for a solution, and we believe there is one. Mark Melman's going to get a little more into detail around the public's perception of this, but let me just say the National Commission said that these issues are very important and are somewhat important to people that they polled, so it's on the public's mind. You see 46% strong support for some kind of voluntary contribution program to this, so the public is becoming aware of their own situation and what they need to do about it. I mentioned the Kerrey Commission quote. Now, what we're proposing is a long-term care solution insurance model. Move away from a government-imposed poverty model into a self-responsibility, government-private sector insurance model. Broad-based consumer participation. We did a actuarial study through the Moran Group, tough group, to say, would something like this work and what would it really cost? Because policymakers say we just can't deal with it. It's just too expensive. The problem is nobody knows. AARP's done some studies, so we have a manageable problem. If we all pay a little the day we start working, and if you become disabled at any adult age, it is based on a cash benefit put in your hands, perhaps through some fiscal intermediary or someone to protect you to make sure that you don't get taken advantage of, but you get to use the money to stay at home. No underwriting, so we're all eligible. Available to all adults, regardless of their age, and Medicaid then is redefined as the safety net. Medicaid has become an insurance program and a large case management system. It doesn't have the money to do the latter, and not the people capacity to do, the former, not the people capacity to do the latter. So Medicaid gets redefined as the safety net. Now, we use some examples. You have to, in an actuarial study, you have to actually put specific things in, including numbers, so that we get beyond this, oh my God, what will it cost? We don't know. So these may not be exactly the right numbers that we ought to come up with. And you may look at it and say, oh, New York coffee is more expensive or less expensive in New York, and people are going to need more in New York than they are in Oklahoma. Granted. But for the first time that we know of, there's an actual actuarial study framework in which you can take numbers and plug them in and see where it'll come out. If we haven't done anything else for the field of long-term care, it's produce a financial model that you can project. So we figured, what if somebody got 1 year's coverage? Cost of a cup of coffee. Not a venti macchiato or whatever, but, you know, it's a Waffle House thing. For 3 years of coverage, what would it cost? And for lifetime benefit coverage, $2.87 a day. And so we began to ask people, and Mark will tell you, what does that sound like to you? What is it worth? Have you experienced it? Would you be? And I found in some informal kind of focus group work that we've done, younger people will say, I've seen this, and I really like the idea of that. I'm not sure I could pay that much. But I've seen some people over 60 or 65 that have gone for 2 or 3 relatives, and you ask them, what would you be willing to pay? Younger people say, I think I could do $20 or $30 a month, and I saw 2 guys in one group that said, I've been through a mother and a mother-in-law thing. I'd pay hundreds of dollars a month to have been able to avoid some of the financial problems. So, but Mark gets into a lot more sophisticated than that. What we said in the actuarial study is that if you put in $2.87 a day in today's dollars, that you would get $75 a day in cash on average. Could be $50 if you've got 2 ADLs, could be $125 if you have 4 ADLs. Doesn't replace the, you still have to have a different reimbursement system for institutional care, just like you do for hospital care. But then you can start playing with the numbers, and the whole system is based on choice, based on responsibility of all parties concerned, and it's fair. Everybody has the same thing. So we started playing around with different kind of cups of coffee, and we were looking for a sponsor for this. I would have put somebody's name on it for the right amount of money, but we haven't come there yet. But we believe that the choice is ours. Now, in Washington, there's interest around this concept through Senator Kennedy's Class Act. We've been very supportive and worked hard because that was driven by interest from the disability community based on cash and counseling model in 3 states that's worked very well and is expanding. When they saw our numbers and our interest, gee, if you pooled a larger sum of money and everybody pays who can so that all benefit when they need it, the Class Act expanded, and we provided the first round of actual numbers to say to them, here's some sound numbers that say generally what this would cost. So we're emphasizing for the long term the importance of the Class Act and a development of a broader sponsorship group for that. I believe, I know Senator Clinton has supported the Class Act. I'm not sure about Senator Schumer. He may have. Senator Obama has. Both presidential candidates have statements in their platforms about long-term care, and you'll see some of the language in both about all of this. So there's an awareness. I haven't heard either one of them talk about long-term care in any of their stump speeches, in spite of all of our attempts to get the call-in show and the host people to ask about it. It is still a topic hard to talk about. And we've asked caregiver groups, because as we were looking at this, framing this PowerPoint presentation, because I had a member of Congress say, if this is such a huge problem, why doesn't my phone ring about it? And we said, well, you know, that's a really good question. So we started asking caregivers. A leader of a national caregiver group said to me, I'll tell you why. Because when I get the call at 10 o'clock on Saturday night that my caregiver hadn't shown up for my mother or she's fallen, the first thing on my mind is not to call my United States Senator and say, when in the hell are you going to do something about this? It's to get the job done. And another said, and after my mother died, I didn't want to think about it anymore. So caregivers do their job. They assume their responsibility. But they're not doing it as advocates. They're doing it as caregivers. And not everybody has sons and daughters, but I'll bet you in your synagogue or your church or in your neighborhood or your building, there are people that you're the informal caregiver network for already, because many, many older people, not enough perhaps, but many have friends that are helping with this. So we concluded it was time to make it affordable to care. It's a moral imperative. It is a fiscal imperative. It is a political imperative. We're to the point now that economics are making us deal with this issue. Short term, I like the Service Works stimulus package that we can name in honor of Bob Kerrey. Short term, long term, we need something like the Class Act or an act like this that says we're going to finance long-term care entirely differently. I asked in a George Mason University public policy master's class as we were discussing this plan a few months ago, and a young woman raised her hand when I asked the question about caregiving, and she said, well, my husband and I just got married. She identified herself. She was a woman with some kind of ethnic background. I didn't ask her, but she was ethnic. And she said, we just got married. We have a small townhouse. I'm working on my master's. My husband works for the government. I work for the government. My 97-year-old great-grandmother just moved in with us because my grandmother can no longer take care of her. That means that my mother and my aunt have now my grandmother and a couple of other older relatives, and I said, we'll be glad to take great-grandma. And I asked her, I said, is that a burden for you? And she said, my great-grandmother is not a burden to me, but trying to find her the help she needs in some way we can afford, that's the burden. Now, we've got to make it affordable to care, and we believe we can do that for the price of a cup of coffee every day. Let's get on with it. Mark Melman.
Well, thank you very much. Pleasure to be with you all, with Larry, with Lois, with Senator Bob Kerrey, who was an old friend and former chairman of mine at the Democratic Senatorial Campaign Committee. So always an honor and pleasure to be with such a hero. Larry asked me to be brief. Someone like asked me to be thin. You can put in the request. Only takes you so far. So I'm going to do my best. I have like a 4-hour sort of Castro-like presentation to give. I have 10 minutes in which to give it. I'm going to solve that problem in 2 ways. First, as Lois suggested, by speaking extremely quickly. But as she said, we're in New York, so it should be okay. Second, there's a lot of data that you're going to see, and you're going to want to look at it. I'm not going to let you. I'm just going to flash right by it. So if you have questions about specific pieces as we go through, please ask them when we get to the question period. Let me start with some of the key findings, and we're using here some data that we've done for ASA, some data we've done for Genworth Financial, some data that comes from other sources as well, to try and put together some insights into long-term care, how to talk about the issue, how the public's dealing with it. First, we should acknowledge and understand that while long-term care is an important concern for the American public, it is not today in any way the preeminent concern of the American public. That's just a fact of life. It's also a fact that most Americans have not prepared adequately for long-term care needs. No doubt about that. We'll see the data. Voters underestimate the costs, and they misunderstand who's going to pay these costs. At the end of the day, though, there is widespread support for national efforts to deal with long-term care of the kind that Larry described. And from a message point of view, keeping older and disabled people in their homes, the costs of care are among the key reasons to address this issue as far as the public is concerned. From a political perspective, Americans say they would think well of a candidate who advocates a long-term care proposal, and very importantly, they want to see long-term care solution enacted as part of health care reform. The broad reach of plan and keeping elderly and disabled people in their homes as long as possible, the strongest specifics that we have to communicate about. There are some concerns that people have, and it's really about taxes and expense at the end of the day. As I suggested, this issue is an important but not preeminent concern. When we ask people how concerned they are about a variety of problems, dependence on foreign oil, the cost of living going up faster than one's income, gasoline prices, health care costs, these are really at the top of the list, with over 40% saying these are one of the things that concerns me most. Other issues somewhat lower down on the list, the cost of health care when in retirement, 26% say that's one of the things that concerns them most as they look to the future. When we get to other kinds of long-term care issues, a little bit further down the list, 22% saying one of the things that concerns them most are the relatively few options and limited availability of long-term care services, not having enough money for retirement, not having the money to provide long-term care or the time to provide long-term care. We're talking about 20% or so saying these are one of the things that concerns them most. Now, don't misunderstand that. That's a lot of people expressing a lot of concern. When you take the next category, the scale that we're using has a 5-point scale, so people could have said it was one of the things that concerns them most, and that's where you get those high numbers on things like the cost of living and gas prices and dependence on foreign oil. But when you add up the people who say it's one of the things that concerns them most, and also those who are very concerned, you're talking about 40, 50% and more of the voters saying these are things that are at least of great concern to them. So a substantial level of concern, again, even if it's not the preeminent concern of the public. But most people have not prepared adequately for long-term care needs. This is part of a survey we did a while ago, but we asked people whether or not they'd made preparations for long-term care. Only 27% of whites, 32% of minorities had made any preparations for long-term care for themselves or for others. When you get up the income scale that people make more than $50,000 a year, that number creeps up, but just barely creeps up to 32%, saying that they've made any preparations. More than 2/3 of people, relatively higher income people, have not made any preparations to deal with long-term care. We asked what kind of plans they've made, and as you can see, people have not made very useful plans. 11% say they've purchased long-term care insurance. 7% say they've saved some money for long-term care. 4% say they've looked at or done research on facilities. So the preparations, even these people that say they're making preparations, they're not exactly the kind of preparations that I think you all would tell them they need to be making. Voters clearly also underestimate the cost and misunderstand who's going to pay those costs. We asked in this study, just for people to guess, if you will, how much they thought it cost to receive care in a nursing home for a year. Well, the average that people gave us in response to this question was about $40,000 a year. The average cost is almost $75,000 a year. So a real mismatch here between what people think is the cost and what the costs actually are. And people also misunderstand who's going to pay these costs over time. Two different surveys here, two different sets of questions. One was an open-ended question on the panel towards me and asked if your family had a long-term illness, if a family member had a long-term illness or disability, had to go in a nursing home, how would the bill be paid? Well, 30% thought the insurance that they have, the health insurance that they have, would pay that bill. 16% thought they'd pay that bill out of savings. 13% thought Medicare would pay that bill. Only 3% thought that their family members would be paying that bill. Social Security, 2%, others, so on. Very few people had a sense of how this gets actually paid. Another question, different survey, different question format, gave people some choices and asked them, if you need long-term care, how would you pay for it? 23% said Medicare is going to step up and pay for that long-term care for them. 21% said their health insurance was going to cover that long-term care. 21% said their savings was going to cover that care. 16% said long-term care insurance was going to cover that care, though, if I understand correctly, the number of people who have long-term care insurance is about a third of that or less. So I'm not sure exactly why the insurance company would step in and pay for it if nobody even had purchased a policy, but somehow people believe that's going to be the case. There is, though, support for national efforts to deal with long-term care, and that support is widespread. In one survey, we asked people about health in the context of health care reform, said, look, this is going to cost some money. If you knew that including long-term care as part of a proposal to reform health care would require additional taxpayer dollars, would you support it? 59% said yes, in principle, I'd support long-term care insurance program at the federal level, even if I knew it cost more money. We asked specifically about ASA's proposal. Every adult would pay $2.87 per day, $88 a month, special long-term care insurance fund. Low-income people, disabled, would be able to participate at reduced rates. Insurance fund would then pay out up to $27,000 a year to cover long-term care services, benefit rising with inflation. Ask people, again, with that concrete plan, do you favor it or oppose it? By a 17-point margin, 53 to 36, people told us they favored this plan. So again, fairly widespread support. That support is particularly widespread among people who have some experience with these issues. So among current caregivers, 57% supported. Among people who have been caregivers in the past, 59% supported. Among people who are receiving care at the moment, 69% support this plan. Where do we not get support? People who have no experience with the issue, people who have not been caregivers or recipients of care. But even they, a plurality among those people, support this plan. But as you can see, that intensity, the level of support, much lower among the people that have less personal experience with the issue. All the parts of the plan receive substantial support, and I want to really direct your attention not to the top here, but to some of the middle items that really sort of describe the core of the plan. the second item here, programs an insurance plan for all Americans. 69% support the idea. Fully funded by the federal government, by participants rather, not add to the federal deficit. 67% support that idea. The core provision, once qualified as needing assistance, participants would receive $27,000 cash benefit. 64% support that idea. Participation is going to cost $2.87 for a lifetime benefit. 61% support that idea. So again, when you look at the specifics of this, break them out, ask people whether or not they support them. When you look at the core specifics, you get very strong support as people are asked to think about these pieces individually. What are the reasons that people support these ideas? Importantly, because they want to keep older and disabled people in their homes, and because they come to understand, as a result of our communicating it to them, the costs of long-term care. So we asked, again, how important each of these, gave people a list of reasons, asked them how important they were as reasons to deal with long-term care issues, and the largest number said the most important reason was the importance of finding ways to keep older and disabled people in their own homes as long as possible. That was disproportionately true among conservatives, among Republicans, among the people that you may not consider the natural constituency of this plan, but for them, keeping people in their homes, keeping older and disabled people in their homes was the most important reason. The cost, the second most important reason. Cost and time and money are beyond what most people can handle. The notion that we're all going to be caregivers and most of us will need help providing that care, also important, particularly among younger voters. So different segments of the population have somewhat different reasons, but when we're talking about keeping people in their homes as long as possible, when we're talking about the cost and time and money, and we're talking about the fact that this is going to be a problem that affects all of us, or most of us in some way, shape, or form, that's what really gets almost 3/4 of the public most involved, most concerned, most interested in this issue. And you see that the people who understand that Medicare is limited, Medicare is not going to pay for this, those are the people who are most likely to support this plan. So again, you go back to this issue of awareness of cost, you see that at the far end, the people who say the reason I'm supporting this is because I know that Medicare won't cover these costs, they support, 72% of them support this idea. Again, further evidence, further indication of the importance of people understanding what they do not now understand, which is who's really going to pay for these long-term care services. From a political point of view, people would like a candidate who advocated this proposal. We asked voters whether or not they would feel more or less favorable towards someone who did advocate this proposal. 52% say they'd feel more favorable. 14% say they'd feel less favorable. Those are pretty good numbers, pretty strong numbers to show to any politician in terms of whether or not there is public support and political benefit for them in supporting such an idea, not that any politician does anything for political benefit. Americans do want to see health, we just put that in there for fun, but Americans want to see long-term care enacted as part of health care reform. Again, we approached this question with this issue with a couple of different questions in the survey. First, we asked people how important it was to them that a proposal for long-term care insurance be part of health care reform. 73%, almost 3/4 of the public, said it is important to them that long-term care be part of a health care proposal. 39%, 4 out of 10, said it was very important to them that long-term care be part of a health care reform proposal. We took a chance with this and took it one step further and made the arguments on both sides. We said to people, look, on the one hand, health care costs are so high, so many people don't have insurance, we really need to deal with those issues first before we deal with long-term care. Pretty strong argument. The other side of that argument was so many people needing help with long-term care. No health care reform is complete unless it deals with long-term care. Even when we put those arguments to people, even when we put costs and coverage front and center and said, look, we just have to deal with those problems first, by 51 to 38, people said no. If it doesn't cover long-term care, it's not really a complete program. We really needed to cover long-term care as well. Another question done somewhat earlier, but asked people earlier in the presidential cycle, asked people, told people that a lot of the, as Larry said, people are talking about health care, presidential candidates are talking about health care, but they're really not talking about long-term care. Do they want to see this debated as part of health care reform proposals? Do they want to see long-term care as part of health care proposals? 78% said yes, they wanted to see long-term care be part of the health care proposals that were being put out by the candidates. That's true among the base of the Democratic Party, but it's also true among the base of the Republican Party. Lesser numbers to be sure, but still 58% of Republicans, base Republicans, were saying, I won't make any partisan comments, base Republicans, no parenthetical notes, were 58% of those base Republicans were saying it needs to be, they want it to be part of, they want long-term care to be part of health care reform. Again, what are the key reasons, the key messages that we can communicate to people? We've talked a bit about that, but we looked at some specific arguments and asked them how convincing these were as reasons to support this kind of plan. Really what's at the top of this list, the single most compelling argument to the largest number of people, is the broad reach of these kinds of proposals, the broad reach of the long-term care issue. That this plan is going to make sure long-term care needs are met not just for the elderly, but people who are disabled by an accident, people who are recovering from a long illness, people who are suffering from chronic disease. All of these different folks, types of folks will be covered, and that broad reach, 41% said that broad reach was a very convincing, not just a convincing reason, but a very convincing reason to support this kind of plan. Right next on the list within a point, it's the best way to keep elderly and disabled people in their own homes as long as possible. Again, we see that notion of people being kept in their own homes, being able to stay in their homes as long as possible, popping right up to the top. Another way, another cut at that issue, many people are forced to move in with children. Families can't afford a home health care aid. This plan is going to help people keep people in their own homes. Different cut at that issue of keeping people in their own homes. But still, again, very high on this list, 39% say it's a very convincing reason. And then, again, this issue of cost. Who's really going to pay this bill? Neither health insurance nor Medicare pays for long-term care. If you live to be 65, you got a 69% likelihood of needing long-term care. Unless you're going to have this kind of plan in place, you're going to face real financial hardship. Again, 37% say that's a very convincing reason to support this kind of plan. We looked at other reasons, some also fairly convincing, others less so. I won't bother to go through the weaker arguments, but again, those stronger arguments focus on keeping people in their home, on the broad reach of these kinds of plans, who's really covered here, and how this bill is not going to get paid otherwise. There are some fears, obviously. We looked at reasons to oppose this kind of plan. For the first thing I want you to note is that the best reasons to support this plan more persuasive than the reasons to oppose it. So we were looking at numbers that were 40% thereabouts in terms of reasons to favor it. The high here is 35% on the other side. And it's sort of the typical anti-government argument, if you will. Just another way for the federal government to increase taxes, contributes to a bloated government in Washington, takes more money out of our paychecks. It's too expensive. It's going to cost $1,000 a year for 40 or 50 years. It's not worth spending $40,000 over our lifetimes to receive $75 a day in coverage. So, you know, again, cost arguments can be somewhat persuasive here with people, too. So these are concerns about bureaucracy, about government, but as was suggested, this is not fundamentally a government plan. We have to meet that objection head on, and we can. This is a plan that's funded by private individuals and gives them choices. Let me just conclude with a couple of conclusions out of this, oddly enough, out of these data, just from a sort of strategic point of view as we think about going forward. First, it seems likely to me that we are going to face a crisis point as inadequately prepared citizens are forced to deal with long-term care. The problem is that crisis is usually not enough, or this definition of crisis is usually not enough to prod politicians into action. Senator Kerrey would remember the last time that the Congress reformed Social Security was not when somebody came and said, hey, we're 10 years out from insolvency. So when somebody came and said, the checks aren't going out next week. Okay? That's the kind of crisis it takes to move policymakers if it's just crisis. So there is going to be a crisis, but that may not be sufficient. And we have to recognize that this issue is not as central to voters, to Americans, as some of the other issues that a new administration is going to be facing, whether it's the economy or energy. Other kinds of issues are going to play a little bit more central role as we go down the road here with the new administration. However, health care reform does provide a critical central vehicle through which to address long-term care. People want long-term care to be part of health care reform. People favor plans to deal with long-term care, and if we don't get it done as part of health care reform, it's going to be that much harder, that much longer, that much more difficult to get it done as a standalone piece once health care is dealt with. So this is, from my perspective, a very critical time, a very critical period over the course of the next months and maybe year when a new health care plan is likely to be developed by a new administration. And then finally, again, just to reiterate, the messages that seem to be strongest and really motivate people focus on the lack of coverage for long-term care by Medicare and health insurance. People don't know that. They need to know it. When they know it, they tend to be much more supportive. Second, the notion that this is not just about the elderly, not that the elderly are not important, but it's not just about the elderly. It's about the disabled. It's about people who are chronically ill. It's about people who are recovering from serious illnesses. Long-term care is costly. People have to understand what these costs are going to be imposed on them. They don't have a good understanding of that at the moment, and they need to. And that a long-term care plan is going to allow the elderly, disabled, chronically ill to stay in their own homes. That is a critical motivating fact for the American public. It's one that we need to attach very strongly to the plans that we're advocating. Let me stop there and turn it back to Larry. Thank you.
What we found in the study, it's a matter of how you, the consumer, sees it. On the one hand, you have a high likelihood that you have a major exposure for long-term care, and you're going to pay out of pocket for that in some way. So if you know you're going to pay, on average, $5,500 a year and could pay thousands more, are you willing to pay $1,000 a year to obviate that need? Now, you could ask the same thing about homeowner insurance. You could say, well, I could not have insurance on my house. Some people in California that live on cliffs don't. Or some people that live in a hurricane that they can't get insurance. You take a calculated risk. If you want to insure against it, what we have is a model that says if you want to insure against this and be able to have some basic level of support, here's what it'll cost. And I think what we're trying to gauge in the public debate, is it worth it to you? Is it worth it to an 18-year-old, a 68-year-old, to insure against the highest risky thing that can happen to you in your life? And my personal conclusion is that I'd like to be insured against that, so I'm not figuring out how to transfer my assets or impoverish myself or whatever to take care of that. I had a guy ask me one time, he was admitted very conservative. He said, you mean I could pay this $40,000 and never get anything? And I said, well, have you ever sold a house? And he said, yeah. I said, did you contemplate burning it down the day before it closed to make sure you got your money's worth on your fire insurance? Well, no. Well, I mean, or do you want to wait for the government to tell you which Medicaid bed you're going to go to and who you're going to share a room with? I mean, these are very real problems, and is this something we want to insure against? And we can tell you that's what it costs. A microphone coming right here.
Could the 20-year-old opt to have the 73-cent a day deduction for the 1 year of long-term care, and then that they might feel is affordable because they're young people who don't make a lot, and then up their contribution as they get older
Sure.
and make more money? I mean, because a 24-year-old might figure that having guaranteed 1 year long-term care was probably adequate if in the next 5 years they were in an accident or
If
something.
you could take the financial model and begin to crank in those kinds of assumptions, Germany went to a plan like this about 12 years ago. because they had some of the same problems we faced, and they sort of eased into it. And now they find that the public likes it so much because people can stay at home and supports them, that people are gladly willing to pay. So there are different variables you could put into the financial model to see what that would look like. What we found out, though, to have the huge impact on Medicaid, the way to have the huge impact on Medicaid is if you will, the $2.87 cup of coffee in which we're all in. If you go much short of that, you can help people, but they're kind of trade-offs of the dollars. If you really want to have an impact on Medicaid, we all ought to be in, and the positive irony of that is that if you pay a little more, it helps the Medicaid program considerably, but you get lifetime coverage. If you pay less, it has less of an impact on you and less an impact on the taxpayer. By the way, I haven't been able to find the source on it yet, but one of our colleagues heard a presentation by somebody, and maybe our AARP has some statistic on this, Lois. There are 280,000 caregivers in this country between the ages of 8 and 18. Think about that concept for a minute. One more question right here. Yes,
yes, hi, Larry. I'm Dawn George. I'm from Pennsylvania, and of course, everybody knows we won the World Series, the Phillies, right? Just had to say that. I couldn't resist.
Oh man, we didn't come here to New York to hear that fight.
At least I didn't wear red.
I'm not sure that most people in New York did know that.
I'm from Washington, D.C. It's just nice to be in any city that's got professional support.
But anyway, thank you for convening this forum. I do have a question, and this is kind of a design question on the program. In the social insurance model, how do you ensure that the beneficiaries receive the care management and they coordinate between medical and housing services? Can you speak to that a little bit? This is more design.
Sure, and in the cash and counseling model, they worried about that as well, but it's worked very well. There have to be sort of honest brokers. Some people can be responsible for their own money. Others have to have some kind of fiscal intermediary help with that. We believe that most of the service infrastructure in this country is already in place. There are methods to determine whether or not somebody is disabled. There are a lot of services in the community. I mean, this room is full of services. It'll make all of us become more entrepreneurial in the service delivery. And what would have to be sort of carefully defined is who decides that you need service and who helps you, if you need it, to manage where the money is spent. Because the fear is that people will take the money and spend it on whiskey, cigarettes, and hookers. And you hear that all the time. You know, you heard that about food stamps, you heard it about cash and counseling. The truth is, that's not how people spend their money. But we believe most of the service infrastructure is in place. What would have to be created is a fiscal infrastructure in which the money is deposited so that it's protected from government intervention. So there have to be some kind of congressional chartered entity that manages the money in a fiscally responsible manner. That's what would be new to be created. We were asked about that up until fairly recently. We said it would be something similar to, say, old Fannie Mae or Freddie Mac, but we quit talking about that. We just kind of changed the whole concept on that one, looking for a different metaphor. Well, perhaps time to get on to the next panel, because we're going to have a group of people now that we've hopefully stirred it up. Try to keep it out of baseball if you can. But I want to thank Lois and Mark very much for your participation.
Okay, thanks.